Welcome to the Deep Dive, where we tackle complex sources to get you instantly well-informed. Today, we're jumping into a really crucial area, the foundations of global psychiatry. We're drawing from a major textbook source that sets out the language and the big picture. And let's start with a pretty sobering fact. More than 1 in 4 people worldwide will face a mental health disorder in their lifetime. This is a massive global issue, a major source of disability. So our mission today is basically a shortcut understanding the core language and the challenging global context around it.
And that context fundamentally is about a crisis of access. We often have treatments that work, that are effective,
Right.
but that knowledge just hasn't translated into people actually getting the help they need. It's not available everywhere. It's not accessible. It's definitely not affordable for many. This leads to what's known as the treatment gap.
Okay, treatment gap. That sounds significant. What kind of scale are we talking about here?
The scale is pretty shocking, actually. The sources point to figures over 90% in some low-income countries.
90%. So 9 out of 10 people needing help aren't getting it.
Exactly, 9 out of 10. And, it's tempting to think this is only an issue in poorer regions, but that's not the whole story. Even in high-income countries, really significant gaps persist. It just underscores how undertreated mental disorders are globally.
Okay, let's unpack that a bit more, especially thinking about younger people. The source mentions about 10% of kids and adolescents are thought to have a mental disorder. But this next statistic really jumped out at me. For adolescents, so that's 10 to 19-year-olds, mental health conditions make up 16% of the global burden of disease for that age group. 16%.
That's huge. And you see this immense human cost running right up against systemic failures in policy. Despite knowing how widespread these conditions are and that treatments can work, the funding for mental health research for treatment, it's consistently described as falling well below what is required.
Especially compared to physical illnesses.
Exactly. Compared directly to big areas like cancer or heart disease, the funding disparity is stark. And it's not just funding, it's also about governance. The WHO points out that many countries either have no real mental health policy at all,
None.
or they're operating under policies that are incredibly old, sometimes dating back to the 19th century.
Wow. That's archaic.
It is, and this kind of neglect has real consequences for basic human rights.
And this is where, for me, it gets really, really concerning. The stigma isn't just social. It's actually written into law in some places. The source highlights some pretty shocking examples from global surveys. Like 36% of countries surveyed actually bar people with mental disorders from voting.
Yeah, it's unbelievable. Taking away a fundamental civic right.
And it doesn't stop there. 37% of countries prevent people with mental disorders from getting married.
Which just reinforces that deep-seated stigma, doesn't it?
Absolutely.
The sources are clear. Shame is a major barrier to seeking help.
Yeah.
And that's true in developed and developing countries. When the government itself imposes these kinds of restrictions,
It sends a terrible message.
a powerful one, it implies this group isn't fully entitled to the same rights.
Are there efforts to push back against this?
Yes, thankfully. Global organizations like the World Health Organization are active. They developed the mhGAP intervention guide.
mhGP.
Yeah. What's key about it is that it's designed for non-specialist health settings. So think primary care doctors, nurses in areas where psychiatrists just aren't available. It's a practical tool to try and bridge that treatment gap.
Okay, that makes sense. Trying to get basic care out there.
Exactly. And they also run Project Atlas, which is basically about collecting data, finding out what mental health resources actually exist around the world, where they are, where the gaps are.
Yeah.
You need that information to target aid effectively.
Got it. Okay, so we've seen the big picture, the crisis, the policy issues, the stigma. But to really understand how professionals work within this, we need the language, right? The specific terms they use.
Absolutely. Precision in language is vital to move beyond those broad, unhelpful labels. So let's cover some core vocabulary.
Where should we start?
Let's start with affect. This refers to the immediate subjective feeling or emotion that's attached to an idea or thought. It's what we observe in someone's expression.
So, how someone seems to be feeling.
Kind of. We talk about the range of expression. Broad affect is considered the normal expected range. But it could be restricted, blunted, or even flattened, meaning their outward emotional expression is limited or almost absent. Or it could be labile, rapidly shifting.
Okay, so affect is the outward emotional weather, so to speak.
That's a good way to put it. Then there's a related but different concept, abreaction.
Abreaction. Sounds intense.
It often is. It's the process where someone brings repressed material usually a painful memory or conflict, back into consciousness. But the key thing isn't just remembering it.
What's the key?
They relive it. They experience the emotions connected to that memory again, quite vividly. It's not just recall, it's an emotional re-experiencing, which can sometimes bring relief from symptoms.
Okay. So different from just talking about something bad that happened. It's about re-experiencing the feeling.
Precisely. That reliving aspect is crucial.
All right. Now, what about this idea of the ego dynamic? How someone sees their own traits?
Yeah, this is really important for understanding why some people seek treatment and others don't. We talk about things being egosyntonic,
Syntonic, meaning?
meaning it feels consistent with who they are. The person sees that aspect of their personality or behavior as acceptable, normal, part of them. It doesn't cause them distress in itself.
Like in some personality disorders, maybe?
Exactly. Someone might have traits, say, manipulativeness that cause problems for others, but to them it just feels like how they operate. It's egosyntonic. And that makes treatment tricky because they don't see a problem within themselves to fix.
Right. They don't feel like anything's wrong with them.
Correct. The opposite is ego-alien, sometimes called ego-dystonic. These are thoughts, feelings, or behaviors that the person finds repugnant, unacceptable, inconsistent with their sense of self.
So this does cause them distress.
Yes, significant distress usually. The classic example is something like obsessive-compulsive disorder. The person knows the obsessive thoughts are intrusive, irrational, not them. They fight against them. That's ego-dystonic.
Okay, that distinction makes a lot of sense. Syntonic feels right, dystonic feels wrong to the person experiencing it.
You got it. And one more quick vocabulary pair. Thinking styles. Abstract thinking versus concrete thinking.
Abstract, like seeing the bigger picture.
Pretty much. It's the ability to think symbolically, grasp concepts, plan ahead, identify common features between different things. It's flexible thinking.
And concrete thinking.
Concrete thinking is more literal, focused on the immediate, the tangible. Difficulty generalizing, understanding metaphors, seeing nuances. It's often impaired in conditions like schizophrenia or some organic brain disorders. They might interpret things very literally.
Got it. Okay, so those are some key building blocks for description. How do these concepts fit into actual diagnoses? Like, how are disorders actually classified?
Right, so clinicians use diagnostic systems like the DSM or ICD, which provide specific criteria. Let's take substance use disorders, or SUDs, as an example.
Okay, SUDs, how are they defined?
The definition covers a cluster of symptoms: behavioral, cognitive, and physiological, all stemming from repeated substance use. The criteria fall into roughly two camps. There are the behavioral ones, things like using more than intended, struggling to cut down, spending lots of time getting or using the substance, social problems caused by use, risky use.
Right, the impact on life.
Exactly. And then there are the pharmacologic criteria. Tolerance, needing more of the substance for the same effect, and withdrawal, experiencing physical or psychological symptoms when stopping.
And how do you determine how severe it is? Is it just yes or no?
No, it's recognized as a spectrum. The severity depends on how many of those criteria someone meets.
Okay.
Meeting just 2 or 3 symptoms typically means mild SUD. 4 or 5 symptoms points to moderate SUD, and meeting 6 or more indicates a severe SUD.
So it's about the number of symptoms showing how pervasive the problem is.
Precisely. It reflects the degree of life disruption.
Interesting. Let's switch gears slightly. What about impulse control disorders? The source mentions kleptomania and pyromania having a specific pattern.
Yes, a very distinct cycle. Both are marked by this feeling of rising internal tension or arousal before committing the act.
Like a buildup.
Exactly, a buildup. And then, after the act, stealing in kleptomania, fire-setting in pyromania, there's a sense of gratification, pleasure, or release. Tension drops.
The tension release cycle.
That's the core feature. And importantly, the motivation isn't what you might expect. For kleptomania, they're stealing items they don't need, either for personal use or for their monetary value. It's not about anger or revenge. It's driven purely by that impulse and the tension release.
And pyromania.
Similar pattern. Pyromania involved deliberate fire setting, again, driven by this impulse and often a fascination with fire itself. But critically, it's not done for monetary gain, revenge, to cover up a crime, or for political reasons. It's about the impulse and the subsequent release.
That cyclical nature is really key then.
Definitely. Now, maybe an anxiety example.
Yeah.
Specific phobia is a common one.
Okay, phobias. What's the breakdown there?
Well, the basic criteria are what you'd expect. A marked, persistent, excessive fear triggered by a specific object or situation. The person avoids it or endures it with intense distress.
Makes sense.
But the specifiers are where it gets interesting. For example, the blood injection injury type.
Oh, right. Fear of needles, blood draws.
Exactly. But what's unique here isn't just the fear. People with this specific type often have a distinct physiological response. Unlike most other phobias where your heart races, here, after an initial brief acceleration, their heart rate and blood pressure can drop sharply.
Leading to fainting.
Yes, fainting is much more common in this subtype than in others. It's a specific vasovagal response. So the specifier tells you something important about the likely presentation.
Fascinating. Okay, one last area, psychosis. The source talks about duration being key to distinguishing between different psychotic disorders.
Absolutely crucial. Timing is everything here. Let's lay out the main fence posts, as you called them earlier.
Okay.
If someone has psychotic symptoms, delusions, hallucinations, disorganized thinking, but they last for a very short time, say more than a day but less than 1 month.
Just a brief episode.
Right. And then they return fully to their previous level of functioning. That would point towards brief psychotic disorder.
Okay, less than a month. What if it lasts longer?
If the same kinds of symptoms are present for at least 1 month, but less than 6 months, the diagnosis shifts to schizophreniform disorder. It looks like schizophrenia, but hasn't hit that 6-month duration mark yet.
Got it. Brief is under a month. Schizophreniform is 1 to 6 months. What about beyond that, or things that mix psychosis and mood?
That brings us to schizoaffective disorder, which can be complex. Here, the person has symptoms that meet the criteria for a major mood episode like depression or mania, and also criteria for schizophrenia.
So both mood and psychosis overlap.
Yes, but here's the critical diagnostic rule. For most of the illness duration, the mood symptoms and psychotic symptoms occur together. However, there must also be a distinct period of at least 2 weeks where they have delusions or hallucinations without a major mood episode occurring at the same time.
Ah, so that 2-week window of just psychosis proves the psychosis isn't solely due to the mood disorder?
Exactly. It establishes the psychosis as a persistent, somewhat independent feature, justifying the schizoaffective diagnosis rather than, say, depression with psychotic features. These duration criteria are fundamental guardrails in diagnosis.
Wow, okay. That clarifies a lot about how these different conditions are delineated based on time.
It's a critical piece of the diagnostic puzzle. So we've covered a lot today, haven't we? We started with that really stark picture of the global treatment gap, the lack of access, the outdated policies.
Yeah, the systemic issues.
Right. And then we moved down to the very specific language clinicians use: affect, abreaction, egosyntonic versus dystonic abstract thinking. And finally, how those concepts feed into the structured criteria for diagnosing conditions like substance use disorders, impulse control disorders, phobias, and differentiating psychotic disorders.
It's a journey from the macro problems down to the micro definitions. So thinking about all this, what's the final takeaway for you, our listener? Reflect on those global gaps, but also those specific legal restrictions we mentioned, barring voting, barring marriage based on a psychiatric diagnosis. It really forces us to ask a tough question. How do we make sure that this necessary process of medical categorization, of defining illness, how do we ensure it doesn't undermine but actually supports the fundamental human rights of individuals? How does clinical understanding contribute to a truly fair, equitable, and genuinely well-informed society?
That's a crucial tension to keep in mind.
Definitely something to think about as you encounter these concepts out in the world. Thank you for joining us on the Deep Dive.